So, good evening again. Thank you very much for the opportunity. So, I bring a case from Onassis Hospital with a primary MR that we did perform about 3 weeks ago. So, it's about a 75-year-old male with recurrent cardiac decompensations and dyspnea NIHA 3. In his past medical history, he underwent a cabbage operation in 2016, and also aortic valve replacement with a serine 23 millimeters. In September, he had a pacemaker implantation due to AV block thread gray, and for his dyspnea, we did a checkup, and the echoes showed us that there was a severe MR. In order to screen the patient, first we made a coronary angiography. As you see here in the video, we have an LCX problem, so that we did before we do the screening for the MR, we underwent a PCI with Onyx TrueCore 2.5 15 millimeters, as you see here, and here is the and angiographic result with a good blood flow. Afterwards, we did also, of course, a right heart catheterization. He has pulmonary hypertension from also pulmonary hypertension, and then we underwent a screening TOE. As we can see in the four-chamber view, we have a prolapse from a posterior mitral valve leaflet with a great Pisa zone and an eccentric jet that goes anterior. In the bicommissural view, that's the A2P2 segment, we see the leaflet and the leaflet, and I don't know if you can see it in the video. We can see here the ruptured quad that is going from the right ventricle to left ventricle, to the left atrium, with a great Pisa zone and the eccentric jet, as I told you before. Here we have the 3D reconstruction, also the MPR on the zone, and we can see the damaged, the ruptured leaflet in this A2P2 segment. And we are talking from a type 2 Carpentier damage, and as we see, we underwent this patient because he was relatively young, 75 years old, but he had primary cabbage surgery and IV replacement, and also he was a little bit of he was frail. So we discussed it in the heart team, and the heart surgeons said he was at very high surgical risk. So we did decide that TEER is the best option for this patient. We decided to go with a mitral clip, and our first option was an XTW because the posterior leaflet was large enough in order to capture it successfully. About the procedure, of course, the patient got intubated, and afterwards we did the right femoral vein puncture under echo guidance. I left it here again. And we went with the catheter in the right atrium. Under echo guidance, we did the transeptal puncture. As you see here, we measure always the distance from the mitral valve ring. In this case, it was 4.1 centimeter in order to have enough space to do the next with a guide. Here you see how we went through the transeptal, through the septum, and then a wire into the left pulmonary vein. here under fluoroscopy, and here you see the echo result. Afterwards, we did through the wire. We went upwards with the guide, with the mitral clip guide, and through the guide, of course, we did deliver the XTW clip. After we went down to through the valve, under 3D reconstruction, we tried to position the clip directly in the P2 flail. Of course, we control it also here in this picture underneath the valve. After we dive in the left ventricle, did the last orientation before we go upwards to the valve. As you can see in these two videos, how nicely both leaflets are in the clip, and then we did the clip closure. Before we undergo any other measurements, the first thing is after the clip closure to see the jet. How much color is there remaining? And as we see here, we have a very minor MR. So we did then the gradient, it was under 5, and we did our leaflets controlling, and as you can see here, I have to do it very slowly, how nicely both leaflets, it was here in this case, how nicely both leaflets go into the clip. So we decided to deplode the clip, and as you see here, it stays stable. We deliver here. That was the end result from the after the mitral clip. You can see that we have only a minor MR remaining, and the gradient was 5 millimeter Hygeia. And we decided to go out with the guide catheter because no second clip was needed. That is the end result in 3D MPR. We see that the damaged posterior leaflet area is completely grasped through the clip, and the result is really nice. And that is the result, that's the transthoracal echo before the patient was discharged. And that was for the day.
So thank you, Maria. I think the interesting point in this case is, if you have a good imaging, then you have a better and a more smooth approach to the patient and maybe a better clinical result. Any other comments from the audience? Dr. Kalogeras, would you do something different? Or in Hygeia, would you use an ACE in this case or not?
No, it was a very good case. I think the XTW, that's a main advantage. I think it was the best decision for this case. It was a fantastic result at the end.
Excellent.
Congratulations for the result, great result, and for the presentation. I think also Pascal ACE would also be sufficient, but of course it was a great outcome with the mitral clip.
Good. So, thank you, Maria.